medicine is weird. Medicine is the only time in which you will walk into a room, meet a stranger, and they will tell you to undress, and you'll be like, okay, that's fine. Hi, welcome to On the Line. I'm Sydney Lupkin, health reporter at Vice News. Today we'll be talking about some of my more recent health stories, including Truvada as prevention for HIV, new LBGT med school curriculum that's being piloted down in Louisville, Kentucky at the University of Louisville, and the right to die.
Great. Thanks for being here, Sydney. First up, we have some Skype callers to ask you questions. And first up, we have Josh in Nashville.
Hi, Josh.
Hey, how are you?
I'm good. How are you?
I'm doing great, thank you. And thanks for having me on the show. Specifically, I wanted to talk about the article that you wrote about PrEP, and about how maybe U.S. doctors are hindering HIV prevention. And you got very graphic early on in the article, which I appreciated, by quoting someone that says that their doctor potentially or allegedly asked them if they wanted to be a cum dumpster. But my question goes a little bit in a different direction to actually organizations. Mainly AIDS Healthcare Foundation. They have been very, very adamantly, let's just say they've been loudly against really getting behind PrEP like the rest of the world or organizations, the CDC, the World Health Organization, the HRC, the White House now with the strategic HIV strategy update that just happened. Everyone's behind using PrEP, or if it's right for people, but AIDS Healthcare Foundation has spent tons of money to kind of tell everyone why it's not a good idea. Do you think that is helpful in the grand scheme of the discussion? And is it a possibility that Michael Weinstein with AIDS Healthcare Foundation has actually caused a lot of this confusion?
So first, actually, let's back up because some people might not know what Truvada is, what PrEP is. We're throwing all these words around, so I want to define them first. So first, Truvada is one of the antiretroviral drugs that is prescribed to HIV patients, to sort of keep their viral loads down, to make sure that they don't get really sick. So then what they'll do for prevention, this Truvada as PrEP, is to give sort of the full dose of one of three antiretrovirals. This one is Truvada, which is actually, I believe, a combination of two antiretrovirals. Now I'm getting a little confusing myself. But basically what they'll do is they will prescribe that every day to people who are at risk of getting HIV. So this, the CDC says, is anyone who is having sex without condoms with partners who may or may not have HIV. So if you don't know and you're not always using a condom, this is sort of something that you can do to protect yourself. And the CDC recommends it. As you said, the World Health Organization recommends it. A bunch of other organizations recommend it. The AIDS Healthcare Foundation is questioning it. They're saying, well, is the CDC right about this? And they're advertising sort of that question, and your question is this causing harm? Is this causing confusion with doctors? And I mean, I think that doctors are paying attention to the CDC and the World Health Organization. So I think that that's important to sort of keep in mind. Should they question things? I mean, everybody should question things all the time. Is it causing confusion? I think that from what I can see, and I'm actually curious about what you're seeing sort of out there, but in sort of my conversations, people are asking the question, what is this? How do I get it? Who do I need to ask about it? And I actually haven't seen a whole lot of, well, maybe I shouldn't take it. I haven't heard that. Have you?
Yeah, I mean, it's a good question. And I have. I think a lot of the talking points that I see on social media come directly from some of that propaganda against the prevention method. And let me just state this for the record, that I don't believe that everyone that's HIV negative should be on PrEP. I think that it's the conversation that should happen between a patient and a physician, or anybody else involved in that decision making, and that we should support whatever decision is made from that. I'm about informed decisions and then not judging people based on that. However, with all of that disclaimer, the statistics are amazing at PrEP preventing HIV. Maybe it doesn't prevent STDs, but the point of that medication is to prevent HIV, and it's doing that very, very well.
If it's taken every day.
Well, yeah, well, and
So
it's
it needs to be
still
taken regularly.
yeah, absolutely, which adherence is always a concern. But even when it hasn't been taken every day, the next question that I have for you is like where condoms fit into the entire discussion. PrEP Truvada is the only FDA-approved prevention method for HIV at all. Condoms have never even been tested or approved for anal sex by the FDA in 25 years. It's crazy to me that we can't even get them to test. And so it makes you wonder, do they know something we don't? I'm not against condoms. All I'm saying is if we know PrEP works, then we should support it. But Gilead is not even really putting money toward promoting it. Why do you think that is? Aren't they the beneficiaries of people taking the medication financially?
So, I mean, financially, in theory, yes. So, actually, I thought about this. So the short answer is I don't know. But I did look into. Have you ever looked at ProPublica's Dollars for Docs? Do you know what I'm talking about?
I've heard of it. I haven't.
So basically, it's online. You can check it out. And what they've done is they've looked at how much pharma companies are spending by paying doctors to sort of speak publicly at conferences, how often they're, taking them out to meals to talk to them about drugs, et cetera, et cetera. And we sort of know that this happens across pharma. And then, so I used this tool and I looked up Gilead, and I saw that their $1,000 hepatitis C pill, now I'm forgetting the name, Sovaldi, I believe it is, that they spent somewhere in the neighborhood of 2.5 million on that. But then I looked down and I found Truvada, and it's not even broken down between Truvada and Truvada as PrEP, and they only spent 55,000. So, and that's again not on TV ads or print ads or anything like that. That's just how much they're spending on doctors and on this sort of promotional Dollars for Docs front. So, I mean, it's definitely worth exploring. But I don't know the exact answer as to why. That's sort of the factoid that I came up with when I was thinking about this question.
That's really interesting, and good for you for finding that. So, one thing that I'm finding in the South, and I'm a very outspoken HIV positive activist that uses social media to encourage people, but also hold people accountable, like insurance companies or prescription benefit companies. And one thing in your article that I thought was really important is that this almost slut shaming, I think is how the article phrased it, and I've heard other places, but that really is happening. I'm in Nashville, and in Tennessee, I've started an underground doctor list for people that are negative that go to their regular physicians and aren't able to get the prescription that they want because their doctor says, "Oh, I'm too conservative for that," which I'm like, you don't have to take the medicine, so it shouldn't be about you, doctor. But I've started an underground list that basically provides PrEP-friendly doctors, or at least how people can get it. But one thing that I don't think that we've talked enough about is, what if condoms took 54 weeks to get access to? And that's how long, and I posted an article on my blog that someone in Louisiana, it took 54 weeks for them to get access from the day they decided they wanted Prep Truvada to the day that they had the pill in their hand. It was 54 weeks.
I
And
mean,
so,
that's probably average from what I've
yeah,
heard. Sorry to interrupt
yeah,
you.
yeah, no. And how does that really speak into healthcare? I know the next article that we'll talk about has to do with just LGBT healthcare in general, but the access of the drug goes beyond just the doctors. It's then once you get the prescription, go into the pharmacy, handing them your insurance card. The insurance companies are denying it the first round almost every time, and then you have to appeal and then appeal again, and then they're finally saying, okay, yeah, we'll cover it, or we'll cover partial of it. But don't you think that speaks larger to kind of these problems that we have with LGBT healthcare in general?
I mean, I think it speaks, I mean, honestly, so wait, the concise question is, sorry, so you want to know, just if you could give me the question in one
Yeah,
sentence. Sorry.
yeah. No, that's okay. And giving it in one sentence is probably impossible for me because I'm a talker. But do you think that the access to this medication translates to the bigger problem of LGBT healthcare in general, not those individuals not having the access that they need for
I mean, sorry. Yeah, I mean, I think, yes. So basically, like, the issue here is sort of almost a personal bias. Is that sort of what you're getting at? That sort of goes to the LGBT med school curriculum where they're sort of talking
Yes.
about, basically one of the big things that they're teaching is, okay, you can believe whatever you want to believe about LGBT individuals, but what you have to do as a doctor, as whatever, is put the patient first and sort of push your individual implicit, explicit biases aside and put the patient first. And that's sort of what they're now trying to teach down at the University of Louisville. And then to sort of just talk very, very briefly, and then I think we probably have to move on, about the prescription and coverage and all of that, I would say to everyone to look into any kind of Gilead coupon program. I think that they do have a program to sort of help people get access to it. And then certain states and cities also have programs that sort of help people get access to them. And if you don't know about them, that's a problem. But like, if you're interested, look into it. So, yeah.
Great. Thank you so much,
Thank
Josh.
you.
Thank you.
Yeah, we have a few other Skype callers on right now, but actually we have a tweet that just came in. Aaron Braun wants to know, what does PrEP accessibility look like for undocumented people? Same question for incarcerated people.
So the short answer is, I'm not entirely sure. But what we know is that sort of the most at-risk populations for contracting HIV are minority individuals, minority gay individuals. So it's very important to get it to them. As far as I know, I think it's probably less accessible to this population. And for incarcerated people, that's another tough one because, these are people who we know, maybe are having sex behind bars. Probably some of them are HIV positive. It's definitely a good question, Aaron. I just don't know the answer.
All right, great. So next up we have Anna on Skype. So hi to Anna.
Hi, Sydney.
Hi, Anna.
Thanks for talking to me today.
Thanks for talking to me.
My first question pertains both to your Truvada shaming piece and the LGBT med school curriculum piece.
Mm-hmm.
It made me wonder how we could hold doctors accountable for what they say that's discriminatory or biased, and that leads to negligent medical care, when conversations between doctors and patients often take place behind closed doors and with no eyewitnesses.
Yeah, so that's tough. And actually, sort of in my reporting, I came across sort of two different situations, and neither of them were really perfectly resolved. So we had the person in the beginning who alleged that when he asked for Truvada as PrEP, he was called a cum dumpster. But the thing is, he didn't, you react to that and you can imagine being horrified and you feel terrible, and the first thing you want to do is, go home and bury your face in a pillow. But I think that if that ever happens to anyone, they should report it to the organization, make a record of it, make sure that the organization, the doctor's office knows that this happened, make sure that the medical board knows that this happened, do whatever you can to make sure there's a record of it. So the other person in my LGBT med school program was the gay man who had strep throat and went into the doctor's office and said, I have a sore throat. And the doctor said, what's your sexual orientation? And he answered honestly. And the doctor said, well, you have HIV, I think, and I can't help you. So that person did make a complaint. And the doctor alleged that, or responded by saying this was actually an insurance dispute. I wanted an HIV test. He had one 3 weeks before, but didn't have a record of it because I guess it was an anonymous free testing facility. And she wanted a new test, but he wasn't covered by insurance, so he wasn't sure how much it would cost, and there was sort of a dispute there. So the long story short is that the medical board, and this was in Kentucky, said, well, we think that there should be a warning, a letter of some kind in this doctor's file, but it's not enough for disciplinary action. So it is hard, I think, when there's this sort of hearsay situation. But as a patient, the best thing that anyone can do is make sure that they report these things, make sure that there's a record, because that's sort of your best bet going forward. That would be my advice.
Great, thank you. My next question has to do with the med school piece. Regarding transgender patients, are the med students at the University of Louisville getting educated not just on the important sensitivity issues like pronoun misusage or not, having trans women in hospital rooms with men, but also on medical treatment specific to the trans population? For example, the right dosage and combination of hormones for trans men or women, or what the various sex reassignment surgeries are.
Sure. So first, it's important to note that with this program, it is the first it's the University of Louisville in Kentucky, but it's the first pilot program through the Association of American Medical Colleges, and they've sort of set, I believe, 30 different areas for standards where they want them to be part of the curriculum. And what this is the first, LGBT education is sprinkled throughout the entire 4 years. However, this just started. So they were developing the first year curriculum, over the summer, over the last year. So those adults, young adults, started over the summer and are working now. And I think that they'll probably go into those things. There is research to say who needs what dosage of hormones. If you're a smoker, what do we do? Because that puts you at risk for blood clots, sort of like if you're on birth control and smoking can make blood clots, and that's not good. So I imagine that those things will be part of it, but I think right now we have to also keep in mind that they're just in their first year, so I'm not sure how much they'll be getting into it. So I know that their first class was a broad class on substance abuse, and what they wanted to do was add in, so it's not just this is everything you need to know about LGBT people in one day, and it's an elective course. Right. This is part of their entire curriculum, and part of that one class was, okay, LGBT people are more at risk for this group, and that group is more at risk for substance abuse. So it's sort of sprinkled in like that. I imagine that it's going to be more than just pronoun usage.
And in that same piece, I just had a question as purely curiosity. With the man who had the sore throat, who the doctor said, oh, you have HIV, you didn't name him in your piece. And I just wondering the journalistic decision behind that. I know it was something about a letter, you read a letter.
So it's a public record. So I had the letter, I had the response from the doctor, etc. But the reason that I didn't name him is because even though this is a public record, I wasn't able to reach him, and I didn't want him to sort of see this yes, he wanted to report it, etc., and that's good. But maybe he, wasn't prepared to see it in this way. I just sort of wanted to give him some kind of warning that it would be on Vice News. And because I wasn't able to reach him, I was like, well, I think this is important. It's clear that this is a public record, so we can talk about it, but I'm not going to name this guy just in case.
Yeah, that's very considerate.
Thank you.
Thank you so much, Sydney.
Thank you. Nice to have you here.
Thanks.
All right, thanks so much, Anna. Great questions. We have one more Skype caller. We have Carolyn in LA. Say hi to Carolyn.
Hi, Carolyn.
Hey, nice to meet you.
You too.
Okay. So before we begin, I wanted to address the ongoing discussion of medical power, such as in the Truvada case with specifically the cum dumpster quote. When a doctor enters a room, they already have an existing position of power over a patient, and a patient is already undergoing so much medical stress in their body that they're just the act of advocating for themselves is like, that's a force of political power. I mean, that's a force that, I don't know, that is a political act to speak up and advocate for themselves in the room. Reporting beyond that takes a measure of strength beyond just speaking up. I'm a queer disabled woman. I'm cisgendered, so I don't deal with trans issues, but I speak with many other people on a daily basis who talk a lot about the strength that they have to summon to just speak up for themselves with doctors who disbelieve their invisible illnesses and in the room. So it's very difficult. Which also says that when you're dealing with a care provider who kind of temporarily ignores their belief structure, such as with LGBT issues, in order to provide care, is that going to inhibit the intimacy necessary in making difficult decisions?
So I feel like there were a couple questions in there, so I might break them up a little bit. So let's tackle this one first. And this is, does sort of ignoring your belief system hurt your ability to sort of care for the patient? And I think in this situation, what they're saying, what the curriculum is trying to do is sort of acknowledge that, yes, there are some people who have biases against LGBT, and sometimes that's just an implicit bias that they don't even know about. And they're acknowledging that. So they want to say, okay, you maybe have this implicit bias, explicit bias. What we need you to do is to push it aside and put the patient first. So I think if you're putting the patient first, then that's the goal. It doesn't matter, how you feel about LGBT people in general. Your focus is, okay, what is wrong with this person? What does this person need? How can I fix it?
Yeah, I mean, that's a platonic ideal in medicine, but there's always, medicine deals with these very intimate issues, such as when to prescribe medicine, when to refer to psychiatric issues, and when to talk about things like sex and death, and when to address these with a patient. And these are things that hit close to home and sort of go beyond the scope of just bodily things, and they kind of cross over into belief systems a lot of the time. So that's when I kind of wonder about whether or not a patient would really be able to trust their doctor or their care provider enough to really believe that they're receiving the best care. I mean, as Josh mentioned with the lists, every patient every patient advocacy group has these secret lists. I mean, I know that I've been a part of a couple of groups, and we have these secret lists because you know who the good doctors are and you know who the bad doctors are.
So in this situation, if you think that you don't have a good doctor, I think if you don't trust your doctor, that's a problem. You need to find a doctor who you trust. And it's a hassle to find doctors in general, not necessarily to find them, but to find one that works for you and you feel really comfortable with. But I think just sort of being very clear out in the open, if someone's not asking you the question, tell them, see how, feel them out for yourself. And I think I think what you're doing is really the right thing. These underground groups talking among people who are, like you, and what do they think, and find the right person. So sure, it can be hard to speak up, and if you don't feel like you're gelling with that person, medicine is weird. Medicine is the only time in which you will walk into a room, meet a stranger, and they will tell you to undress, and you'll be like, okay, that's fine. So, yep. So, it's important to find someone that you're comfortable with, and if you're not comfortable, get out. Go find someone else. Don't get out completely, which is one of the issues with why they're sort of creating this pilot program, is that LGBT folks are not always going to the doctor. If you have a bad experience, you might not come back for a year. So I think, finding the right person, talking to your peers, who can maybe help you find the right person, that's important, and you're doing the right thing.
Thank you. Mm-hmm. The other article that I had questions about was about your article on the right to die legislation.
Yep.
And as a person with a disability, I'm wondering about the greater restrictions on pain medications in our country that are being pushed at the same time as the right to die legislation. And it seems to me and a lot of other people in the disability rights movement that this legislation is less about our quality of life than it is about controlling our bodies.
So I think, a lot of that legislation is to prevent sort of addiction to prescription painkillers, correct? Is that what we're talking about? Kind of?
Kind of, except you can't really prevent addiction. Addicts are going to access medication any way that they can. And really...
Well, I think they don't want... I'll let you speak. Sorry.
Really, if we addressed things like mandatory sentencing minimums, we could sort of circumvent a lot of the issues in right to die and give patients more bodily autonomy, which is one of the things that Brittany Menard talked about repeatedly in her, as you wrote, very moving video. But bodily autonomy is not something that Right to Die actually gives patients with disabilities.
So it's an interesting question, and I hope I can answer it well enough. Actually, one of the questions that I had from some Stanford doctors who were sort of in the hospice world was about this, and one of the things that because they're at Stanford, so they're in California, and they don't have the right to die yet. They don't have this legislation. It's something that I think they just reintroduced last week or the week before. Now time's getting away from me. But they said that when their patients in hospice in end of life ask them about end of life care, they usually had an underlying reason for doing so. Their pain wasn't being managed well. No one had talked to them about what dying might actually be like with their illness, things like that. They just didn't know. They didn't feel like they had control. They didn't feel like they had all of the knowledge. And they said once they started addressing those things, their patients stopped asking for the right to die. I'm not necessarily saying that it's not something that is... it's tough. But that was just sort of an interesting thing that I didn't get to put in the article. At least I don't think I did.
But I think that those are things that come up with intimacy in illness and the intimate nature of a doctor-patient relationship that I think that doctors and patients need to have. And I think that these are discussions that need to happen early on in the diagnostic process. And I also think that rather than fighting for right to die legislation right now, we should be fighting for access to care across the board as early as possible, and access to medication as early as possible, and access to all of the care possible as early as possible, and as economically viably as possible.
Right.
Rather than pushing us out.
Right. These are all very important things. And I think there's probably, right to die is definitely something that no one wants to necessarily talk about until you really get farther down that road, because I think there might be, and I, truth be told, I don't know for sure, but you also don't want to scare a patient. I'm sure that there's an issue there as soon as they're diagnosed. Well, you disagree? I'm curious.
I mean, I think that it is something that you have to start talking about as soon as you can. And I think that you have to start talking about end-of-life options. I've been in hospital situations where they've talked to me about dying in a ham-fisted way, and they haven't been doctors that I've seen before. They've been new doctors, and they've just talked to me about, okay, well, you should start considering this. Your quality of life is going to be awful. And they've just told me these things. And if I wasn't an advocate, and if I wasn't as informed as I was, and if I wasn't me, basically, I would be a lot more depressed. I would be devastated by the things I was being told. And it's just not the way it should be done. You should really have these conversations with your doctors earlier, and there should be trust and intimacy between doctors and patients. That's it.
Yeah, no, I mean, it's all a good point. And your experience is very valuable. And I think probably for this particular issue contributes more than I do to this show. So thank you for sharing it with us.
Thank you.
Yeah.
All right, thank you very much. It was a very enlightening and important topic to talk about. Why don't we say thank you to everyone watching at home?
Okay. Thanks so much to everybody watching. I'm Sydney Lupkin, health reporter at Vice News, and this was On the Line. Thank you.
You need to understand that people are coming in begging for this drug, and they know they have to take it every day, and so they do.
I think we could be sitting on something that could change the course of this epidemic. I think it remains to be seen how well we can make PrEP available.